So today we'll be talking about the third nerve, and more specifically the third nerve palsy. The third nerve is also known as the oculomotor nerve, and it's in charge of a few things, a few functions in the eye, such as the levator function. So in a third nerve palsy we might see a ptosis. This ptosis can be complete, it can be partial, it can be covering the pupil, it might not be covering the pupil. Another thing you might see in a third nerve palsy is a dilated pupil. So third nerve palsy can be pupil sparing and it might not be pupil sparing, and there's what you see when it's not pupil sparing. And when you get a torch and check if it's reactive to light, the pupil might not be reactive to light, it might be a little reactive to light, or it might not react to light at all. The third nerve supplies a few of the extraocular muscles around the eye, such as the inferior oblique, the inferior rectus, the medial rectus, and the superior rectus. Now these mixture of muscles make the eye movement down and out. So a person with a third nerve palsy will have a strabismic eye with an exotropia and a hypotropia. So the third nerve has two branches, the superior branch and the inferior branch. The superior branch supplies the superior rectus and the levator, which is the muscle in charge for your lid. And this is the reason we have the ptosis here. Now the inferior division supplies the inferior oblique, the medial rectus, and the inferior rectus. And it also supplies the ciliary ganglion cells, which are used for constricting the pupil. And this is the reason we might have a dilated pupil. The third nerve palsy can be divisional, so it might just be the superior branch that's affected or the inferior branch that's affected. Everything can be affected, or it can be specific muscles that are affected in a third nerve. So the third nerve nucleus, like all the cranial nerves, starts at the brainstem, over here specifically in the midbrain. So the third nerve nucleus runs forward through the subarachnoid space over here, and at this point the third nerve nucleus is parallel to what we call the posterior communicating artery. The posterior communicating artery here is very important in terms of the etiological factors of the third nerve palsy. The PCA's job is to communicate between the anterior and posterior surfaces. So let's say, for example, there's an aneurysm at the PCA. So let's draw an aneurysm here. It is likely to hit the third nerve, therefore damage it, giving the patient a third nerve palsy. So if a patient is seen in an acute new third nerve palsy, whether it's partial, complete, whether it has pupil involvement, has a ptosis, the thing to always look out for is a PCA aneurysm over here. So if you're presented with someone with a third nerve palsy, it's important that you check if the surrounding nerves are functioning correctly as well. So these nerves include the fourth cranial nerve, fifth and sixth, starting with the fourth cranial nerve, which is also known as the trochlear nerve. So this nerve is in charge of the superior oblique. To test if the superior oblique is functioning correctly in a patient, you get them to look in depression. And when you get them to look in depression, you're testing for intorsion. So the primary action of the superior oblique is intorsion. So if you get them to look in depression, you'll see the eye turning inwards, so nasally, in towards the nose. And if you see that, you'll know that the fourth nerve is functioning perfectly fine. So it's also important that you test for the fifth cranial nerve as well, as it sits very close to the third. So the fifth cranial nerve is known as the trigeminal nerve, and it has motor and sensory components. Now, a patient with the fifth cranial nerve palsy will have jaw irregularities, so the jaw will be affected ipsilateral to the lesion. And to test for the sensory components, you can test for corneal reflex and temperature and pain. Moving on to the sixth nerve. The sixth nerve is also known as the obducens nerve, which is in charge of the lateral rectus. which abducts the eye. So someone with a 6th nerve palsy, you will see something that looks like this. So the patient won't be able to abduct the eye over here. So this will also give them an esotropia.